The purpose of this strand of the research programme was to explore what people need, what they want, and to look at how we can best evaluate different approaches to providing services and care. We chose both to look more generally at the wider questions of what people want, and also to choose two specific areas of problems where we would evaluate particular interventions that we're trying to improve service delivery. This programme of research was a collaboration between Trinity College Dublin, particularly the Centre for Health Policy and Management, the University of Limerick, and the Queen's University in Belfast. They brought skills from psychology, from psychiatry, from health economics, and from nursing, all of which are relevant to a programme of this sort. As I will describe, we provided this programme of research through 3 individual projects. The overall project that was looking at what people want and what are the patterns of their preferences was based on a broader study that's been carried out over the last few years in collaboration with people in London and New York. But in this case, we were very specifically looking at how can we best understand what people's preferences are at this crucial time in their life. The approach we took to this was to use what is called discrete choice experiments. That is to say, we ask people questions in a survey that allow us then to work out what the underlying patterns of their preferences look like. So, for example, we'll give them choices between different packages of care, and by looking at their choices between these packages, we can work out how much they value the different elements of those care packages. The other 2 studies in this package of work looked at 2 specific interventions around problems that have not always been very well managed in the past. These are cachexia, that is to say, the loss of appetite and the loss of ability to eat properly, and delirium, that is the loss of an ability to cope through confusion and becoming unable to make decisions. In the case of the Cachexia study, we were trying to do a pilot trial of using an information and communications technology approach to informing caregivers about this problem and about how they can best help to manage it. In this case, it turned out to be very difficult to persuade people to participate in the study. At this particular time of their lives, with a very sick relative or friend, they were really not able to engage with the possibility of looking at participation in a trial of this sort. Even though we were able to demonstrate that where people had used this intervention, they found it very helpful. In contrast, in the case of the delirium study, we were dealing there with ways of supporting people who have very obvious and very important problems. It was found in this study that this loss of ability to cope was also very strongly associated with depression, a problem that is often undermanaged near the end of life. What we found in this case was that it was quite feasible to have a quicker and more efficient way of diagnosing depression in this population, and to be able therefore to treat this symptom, which was closely associated with delirium. A new tool has been developed which is now available for use, and it allows us to see this problem in a much clearer way. So what have we learned overall from conducting these studies? Well, the first thing I think is that people are in general keen to take part in studies of this sort, but, and it's an important but, they will only take part in these studies if they see it as being closely related to their role as being a patient or a carer in the period near the end of life. What we've also found, though, is that there are some practical things we can do differently as a result of what we've learned. We know, for example, that preferences of caregivers and patients are similar but not exactly the same, so that the use of caregivers as proxies for the patients may or may not be an appropriate thing to do in some circumstances. Similarly, we've learned that people are very keen on process, and very keen on good process when you're dealing with care near the end of life.